All right. Well, hi everybody and welcome. Sorry for my my entrance just now. Um I think Kathy, Dr. Jacobson came and spoke, oh, was it about 6 months ago? And we were planning on doing a two-part series because we were going to talk a little bit about hepatitis C, which has become a big interest in our group. So that is what she is back to talk to us about, a test and treat model. So I'll do a brief introduction since I'm sure everyone remembers everything about her from 6 months ago. Dr. Jacobson is the chief of the STD control branch at the California Department of Public Health, where she supports the administrative, programmatic, scientific, clinical, disease investigation, policy, epidemiologic, and surveillance teams for STIs, Hep C, and Mpox for Californians. She also serves on the disaster medical assistance team for the U.S. Department of Health and Human Services, responding to natural and public health disasters, and is on the board of the directors for the HIVMA for the Infectious Diseases Society of America. Um, a recent senior HIV, TB care and treatment advisor for the U.S. Center for Disease Control to the country of Uganda. She contributed to the revision of their national HIV TB guidelines. She was the previous medical director of the LA Region PATC Center, or PATC, where I realized she probably worked with Dan over the years. And she's had extensive experience in workforce development, capacity building, and technical assistance to clinical systems and emergency departments. Um, she's a board certified family physician and HIV Medical Association HIV specialist with over 30 years of clinical experience, including the full spectrum HIV primary care, emergency room consultation for patients with HIV and STI, and hospitalists, including management of ICU and urgent care. There's more to Dr. Jacobson, but I'd like to turn this over to her. And we're really happy that you're back with us, Kathy, and we'll turn it over to you. Dan's going to be moderating, but I'll be listening in as well. Thanks so much.
Yeah, thanks. Jill and I know each other from the California Collaborative Treatment Group since 2012 when we did some of the early PrEP implementation studies for California. So yeah, thanks everyone. And really we're going to focus today on hepatitis C test and treat. And as most of you are probably aware, UC San Diego received funding in their emergency department. That funding ended in April of this past year, but hepatitis C testing was part of that program. So we'll briefly cover California surveillance data, talk through risk factors, which I'm sure you all know, the impact of injection drug use on hepatitis C treatment, what current guidelines recommend, the impact of adherence on treatment, and then walk through a test to treat algorithm that we created for the emergency departments, and then they helped us revise to make it even further simplified to work in the emergency department. So in California, the rate of newly reported chronic hep C cases decreased between 2020 and 2024. However, when we look more closely at that data, the decline in the newly reported cases is mostly due to the fact that there's a decline in probable cases. In 2022, California Department of Public Health was able to start receiving from laboratories hepatitis C RNA negative results. So we were able to remove the probable cases when the hep C RNA test was negative. And that accounted for about 63% of the decline in reported chronic hep C cases. Despite that, there is still about a 17% decline in reported chronic hep C cases. However, despite these declines, according to the CDC, the rates of acute hepatitis C has been increasing and increased roughly fourfold since 2020. So maybe cases are going down, but this might suggest that they're not and that we're not identifying all of the chronic cases. Newly reported chronic hep C case rates were highest among persons aged 30 to 39 in 2024. And non-Hispanic white, Black, African American, American Indian, and Alaska Native persons were disproportionately affected by newly reported chronic hep C cases in 2024 in California. So let's take a moment and talk about a case. You have this 39-year-old white male who presents with an abscess on their left hand. They've had a history of a previous cellulitis on the same arm, and their social history is that they're an injection drug user. And you can see the cellulitis on the exam. Their labs, their chemistry panel is normal. They have a EGFR of 75. Their white count is 13,000, 86 neutrophils, an H&H of 12 and 36, and platelets of 170,000. And in the emergency department today, their routine screen for hepatitis C antibody test comes back positive. Their HCV viral load is pending. And my question for you is, could you start hepatitis C treatment on this individual today? So one of the biggest concerns folks have are the fact that this individual is an injection drug user. And as you know, roughly 60% of individuals who have hepatitis C, injection drug use is the source of that infection. About 15% of the time, it's due to sexual transmission, 10% due to transfusion, 5% other, and that other is nosocomial healthcare, as well as perinatal, and about 10% of the time, the source is unknown. So the simplified trial looked at treatment outcomes among people who inject drugs. And they looked at the safety and efficacy of Sofvel, and I'm going to use the shortened terms on all of these so that I don't mess up these words repeatedly, in treating chronic hep C among people who inject drugs. Individuals had genotypes between 1 and 6. They were treated for 12 weeks. And the primary endpoint was an SVR12. And they found that there was no significant difference in SVR rates between injection drug users and those without injection drug use. And this was one of the early studies that supported the inclusion of people who use drugs in treatment guidelines. Then this was a meta-analysis that looked at treatment outcome among people who inject drugs in patients on opioid substitution treatment. There were 11 primary articles and 12 conference abstracts. There were over 1,700 patients on opioid substitution treatment, 538 individuals who injected drugs, and over 19,000 controls. And when they looked at the opioid substitution pooled SVR, they found that 90% had SVR. And the pooled discontinuation rate was only 7%. For people who injected drugs, for people who injected drugs, the pooled SVR was 88% and the discontinuation rate was 9%. So their conclusion was hepatitis C treatment outcomes in people who inject drugs and patients on opioid substitution treatment are similar to those in patients without a history of injecting drugs. And this study looked at community-based test and treat, and they compared community test and treat versus clinical care. And among 713 treatments commenced amongst people who inject drugs, SVR was 91% among the community test and treat individuals. Almost half of those treatments came from needle exchanges and community pharmacy treatment sites. And they found there was no difference in the likelihood of SVR and rapid hep C treatment for people who inject drugs in community settings relative to hospital or clinical care. So these are this is some of the data that supported AASLD and IDSA to develop a simplified treatment regimen for test and treat to expand the number of healthcare providers who prescribe DAAs, to increase the number that receive treatment and prevent the transmission and disease progression. And this really aligns with a number of national and international strategies. The national strategy for the elimination of hepatitis B and C, the 2025 strategic plan of the Division of Viral Hepatitis at CDC, the National Strategic Plan for the US, a roadmap to elimination in 21 to 25, and the Viral Hepatitis Elimination Guidance from the WHO. So the simplified treatment regimen, as most of you are probably aware, for adults with chronic hep C and any genotype without prior hep C treatment and without cirrhosis or compensated cirrhosis, they can take either one of the two regimens, either GLA-PIB for 8 weeks or SOF-VEL for 12 weeks. And they said that no laboratory monitoring is required for these patients while they're on treatment. And they may, but do not need to schedule an in-person or telehealth visit during their treatment. So they can do it to support patients to assess for symptoms and or new medications, but actually they don't have to do it if patients are less inclined to follow up anyway. And because of this, in October of 2025, the Department of Healthcare Services updated its contracted drug list to remove the limitation of 28 days quantity on hepatitis C medications. So prescribers can write a single prescription for the entire course of the hep C treatment, either the 8-week or 12-week course, and dispense the entire treatment course upon initiation to help patients achieve virologic cure. And this was supported by the Midmont study that looked at 12 weeks of SOF-VEL, had no follow-up visits, and SVR was 95%, SVR 12. So in California, however, only 1 in 3 or 36% of people with known hep C infections have evidence of clearance or cure in 2024. So as you can see, despite the simplicity of treatment, despite the ease of being able to prescribe the entire course, we still only have about 1/3 of individuals who achieve clearance or cure. So then the question comes up, well, you know, a lot of providers will say that they're afraid to treat or afraid or concerned about treatment because patients are not going to adhere. So what do we know about adherence and how that impacts SVR? So the HERO study looked at overall SVR rates and found that they were 92.7% if median adherence was 75%. But if patients adhered 50% or more and had less than 26 consecutive days of missed medications, SVR rates were over 90%. So only 50% adherence, as long as they don't miss 26 days or more in a row, SVR rates are over 90%. And the PREVAIL study showed that 96.5% SVR 12 if there was overall adherence of 75%. And they also found that the total doses in the first, in the middle 4 weeks, when it was a 12-week treatment, were significantly associated with SVR compared to the last 4 weeks. So really those first 8 weeks seem to be critical for the 12-week courses. But how much is too little? For a patient who does not have cirrhosis and therefore they're eligible for 8 weeks of treatment, they found that 4 weeks was sort of the cutoff. If you had less than 4 weeks of DAAs, then you had about a 50% SVR rate. As soon as you got over that 4 weeks or more of treatment, SVRs went up to 99%. They also looked at compensated cirrhosis 12-week treatment courses, and 8 weeks was sort of the cutoff. Less than 8 weeks had 83% SVR, and over 8 weeks had 95% SVR. So let's go back to our case. A 39-year-old white male with a history of injection drug use. He has a left hand abscess, previous medical history of cellulitis, a history of injection drug use. Again, we said his chem panel was normal. His GFR is 75. His CBC shows platelets of 170,000. He's antibody positive. His viral load is pending. Can you begin Hep C treatment on him today? Well, this is a test to treat algorithm that, as I mentioned in the beginning, we produced this for the emergency department screening program to simplify test to treat. We've received feedback from 28 emergency departments on this and further simplified this test to treat algorithm. So if you start at the top where the HCV antibody test or an HCV RNA viral load test is reactive, you can have either one positive. If the answer to that is yes, then the first question you want to ask is, has this patient begun treatment or been treated for hepatitis C before? If the answer to that is no, then you move forward. If the answer is yes, if they've been treated before, then this is probably a patient who, if you're talking in the ED or you're talking an individual with less experience with treatment, then that's probably someone who needs to talk with a specialist about their Hep C treatment before it begins. If they've never been treated for Hep C before, then you want to get a CBC, chemistry panel, HIV test, and pregnancy screening test today. You want those results today before they leave. You also want to send off your hepatitis C RNA viral load, and you want to get a hepatitis B panel. However, if their platelets, GFR, LFTs, are normal, their HIV test is negative, and they're not currently pregnant, you can move forward with treatment in an individual. You can empirically treat for Hep C while you're waiting for the Hep C viral load to come back, while you're waiting for the hepatitis B test results to come back. And you can treat in someone who does not have cirrhosis, you can treat them with either GLA-PIB or soft-vel for the appropriate time course for those medications. And as we said, of course, you want to refer them for follow-up and for, to have them follow up. But if they do not follow up, as you can see, it's really not the end of the world. This is a course of treatment you can give them, and if they take more than 50% of it, they're probably going to do fine. If, on the other hand, you have abnormal platelets, if you're HIV positive, if your GFR is less than 30, if you have a positive pregnancy test, or you have a history of other liver diseases. So now I'm over in this red box over here, hepatocellular carcinoma, history of liver transplant. Those individuals, you may want to hold treatment on today and talk with a specialist before beginning treatment. And then I'm going to continue to follow this abnormal line down here. If they have cirrhosis or platelets less than 150,000, and hepatologists will tell you if platelets are less than 150,000, that's significant for them probably having cirrhosis. Of course, there can be other reasons for why they have low platelets, but in an individual who otherwise does not have any major medical problem happening, a low platelet count is considered consistent with cirrhosis. So those individuals can still start treatment, but they need to be treated for 12 weeks instead of 8 weeks. So they're going to get soft-vel instead of GLA-PIB for their treatment. Any questions on this before I move forward?
We can open it up and see. I just put in the website in the chat for people to access.
Oh, Great.
Any questions? Nope. Okay.
Okay. All right. I'll keep going and happy to answer any questions as they come up. So one of the big questions is always hepatitis B reactivation. Um, and estimates have been anywhere from 2 to 10% of hepatitis B co-infection with hepatitis C. However, a large cohort found that it was really about 1.4% of hepatitis C infected individuals are co-infected with hepatitis B. Um, Also of significance here, because remember I said that you could start treatment while you're waiting for your hepatitis C, or I'm sorry, your hepatitis B panel to come back. And the reason why you can begin that treatment while you're waiting is typically reactivation, if it's going to occur, typically occurs between weeks 4 and 12 of DAAs. And it is possible that reactivation can actually occur either at or greater than 3 months after you discontinue your DAAs. The risk of clinical flare is roughly 9% in those that are co-infected. So there's a net risk of roughly 0.5% of individuals who are co-infected with hepatitis C, hepatitis B, and have a clinical flare. So the risk is very low. And if it's going to happen, it's unlikely to happen in that first week or so of treatment while you're waiting for your hepatitis B panel to come back. So it is reasonable to start treatment while you're waiting for those results to come back. And as a reminder, only 1 in 3 individuals with hepatitis C have evidence of clearance or cure in California. So what if they do turn out to have hepatitis B? Then really the management is not that complex. If they meet hepatitis B treatment criteria, which there's a number of reasons for treatment, most common is a viral load over 2,000, but those individuals should be started on their treatment for hepatitis B, which can be tenofovir, TAF, or entecavir. So you can co-treat them. TAF is contraindicated in individuals who you think have decompensated cirrhosis. If they're co-infected with HIV, most of you know this, right? That you use Truvada or FTAF. And again, FTAF would be contraindicated if an individual has decompensated cirrhosis. And their treatment for hepatitis B should continue post-treatment for their hepatitis C. If they do not meet the criteria for hepatitis B treatment, then the recommendations are one of two. You can just monitor the hepatitis B DNA and AST and ALT roughly every 4 weeks while they're under treatment. Or, depending on the individual, you could also consider empirically putting them on tenofovir, TAF, or entecavir through the course of their DAAs in up to 12 months post-treatment. And that's post-treatment for the hepatitis C. And that 12 months is there because of these, lower risk, but risk of possible reactivation more than 3 months after DAAs are discontinued.
Kathy, can I ask a question? With with co-infection, while you can get the full treatment for Hep C, how much Hep B treatment are you able to get, and does that become challenging because you can treat one, but the other one requires probably more follow-up?
Yeah, that's a great question. Yes, to my knowledge. And interestingly, hepatitis B and hepatitis C are separate at the state. Hepatitis B is under our immunization branch, and hepatitis C is with our STI branch. But to my knowledge, depending on your insurance, you're going to get anywhere from 30 to 90 days. It seems like more insurances prefer the 90 days, but you're certainly not going to get, a full year of treatment for
Right.
hepatitis B. Yeah, that's a great point.
Okay. Thanks.
Can, can I
Yeah,
just add one thing while there's a pause? Um,
sure.
yeah, so just there were two general comments. It was from the test and treat model, and I know we gave this feedback to you from our ED. The issue with not having the Hep C viral load back is the concern about having to treat someone who actually, either didn't know that they were already treated or, cleared on their own. And so you'd be starting a regimen on someone who didn't actually need it, which would obviously be a waste of drug, which isn't nominal. It's costly. So that was the first thing from our standpoint about waiting for a viral load. And then the concern with not having the hepatitis B surface antigen is clearly once you have that, there is some additional follow-up that you need to have. And our assumption with test and treat is that we may never see this person again. That's sort of the way we're thinking about it, even though obviously we're trying to set follow-ups, we're trying to be in touch with them. But if the assumption with test and treat is you may never see this person again, then at least from our vantage point, we need to have all that information before we can actually feel comfortable saying, here's a full course of medication. And then
Yeah, yeah. And I think
is remember that's only, sorry.
no, no, I'm just listening. You're cutting out a little bit, so I was just making sure I'm hearing you
Yeah,
completely.
I'm sorry. Sorry. Can you hear me now? I now just went down to one bar, so I'm probably useless. Can you hear
No,
me at all now? I
Yes.
I heard
apologize, everyone.
first.
Okay,
Yeah,
okay, sorry. I was just gonna say with the full treatment course that you can get, that is only with Medi-Cal and with Medicare and PPO plans. Many of them require smaller prior authorization, and many of them are still only giving 1 month at a time. So I just wanted to make that point. That is something that we're grappling with and figuring out. And obviously, we can talk a little bit about our experience if there's time at the end. But I don't know if you said you can get a full treatment. I don't know if you said for everyone, but it really is only for people with Medi-Cal.
yeah. So, correct. That is correct. So for folks who didn't hear Jill, the ability to write the full course of treatment has been approved for Medi-Cal, but it has not been approved for, each insurance company is going to address that. Private insurance is going to address that differently. We don't know how all of the insurances address it. So, yeah, that is unfortunate, but that is true. Um, as far as prior authorization, there's no prior authorization for Medi-Cal patients. There is currently a bill that is under review. I believe it is currently sitting on the governor's desk, called AB 1843. And that bill is hoping to remove prior authorization for private insurance. So all insurances, so not just Medi-Cal, but all insurances. That I think, at this point, we don't know if it will be signed or not, but we know that bill is sitting. It's either on its way to the governor's desk or it's on his desk amongst other bills he's got for this particular fall. So fingers crossed on that, but we don't know. What else there's something else. Oh, you were saying you weigh the risk of starting treatment on an individual who may have cleared. And as you all know, historically clearance has been roughly 30%, although there was a recent abstract that just came out that looked at clearance across over 3.5 million individuals and found that clearance was as high as 39% across those 3.5 individuals. They did a data extraction from EHRs. So it could be as high as 40%. So agree that that is a consideration that you certainly want to take into account. You have to weigh that with, um, the chances that you may never see that patient again and not be able to treat them, and they may be then going on and infecting other individuals. So I know it's a fine line, and I think there'll be instances where the likelihood that that positive antibody test is in fact a true positive are probably greater than situations where it's not. And ultimately, this is all a clinical call. What we're hoping to share with you is that it is possible. This is the data that supports it, and some of the concerns about hepatitis B reactivation, that net risk is much lower than was historically thought about. So, and you've got some time. Agree if you can't reach an individual that there's more concerns about whether or not you have that time. Now, there's other things that you could do, such as empirically treat them for Hep B if you think they're going to have Hep B. Not that I'm saying that. And there is a point of care Hep B test that is in the pipeline, but not yet fully approved in the US that will help with that. Did I cover everything, Jill?
You got it. Thank you.
Yeah, yeah.
Yeah, there were some comments in the chat from Kathy Promer. I also wonder if insurance would cover without an RNA. And I don't know. I guess some insurances may be requiring an RNA before, or at least proof maybe before coverage. I don't know if
Yeah,
you've run into that issue.
yeah, we haven't heard from anybody that they've run into that issue. But I'm sure that will, you know, become an issue as more people do test to treat. I think, you know, like anything, when the clinical case supports it, you can usually uh, overcome that. And if they remove prior authorization, then that shouldn't be an issue.
Okay.
But time will definitely tell.
And then there was another comment from Nettie Aldis. Have any of the test and treat programs used dedicated patient navigators to follow up on patients when they leave the ER?
100% of, so there were 28 emergency departments that were funded by California during the previous round of funding. And it was a requirement of all of the emergency departments. It was part of their required milestones so that they have patient navigators to receive their funding. So 100% did. And so, that is a piece that really does help with that follow up, and they can follow up with the treatment piece of it. They can do follow-up phone calls, etc.
Okay. And then the comments are coming in now.
Yeah.
From Adam, from Tom Martin, is there scope for negotiation with pharma and insurance where payment is cure dependent? It would increase start rates potentially, and the drugs themselves are cheap.
So meaning there's reimbursement for curing? Not trying to follow exactly what you're saying there. I
Yeah,
think
I'm
it's an
sorry.
interesting idea. Yeah.
Yeah, there's precedents in the cancer world where where payment for courses of expensive meds depend on success of the outcome. Because what we want is to just get more drug into people's hands.
Mm-hmm. Yeah.
Oh,
Interesting.
then I think insurance companies would be less reticent to give the drugs out.
Interesting. I'd be happy to have somebody send that to me. That's a very interesting idea. And didn't know that. So yeah, if somebody wants to email me, I know Marvin and Jill have my email, and you want to share that with me. That's very interesting. So yeah.
And I think last question from Adam Bortner. I had an issue last year with where a specialty pharmacy delayed filling a second month of Sofvel for a patient until they confirmed Hep B status.
Interesting. Um, that's very interesting and very disappointing to hear. I would be interested to learn what pharmacy, I don't know if that's a small local pharmacy or if that's a larger pharmacy chain, because we can sometimes meet with, some of the larger chains and explain things, because, yeah, that's definitely concerning.
Yeah, and he said it was CVS Specialty Pharmacy.
All right.
So,
All right. Thank you.
yeah.
Yeah, we'll follow up on that.
Okay, so that's it on the questions for right now.
All right, great. Okay, and for HIV, which, I know you all are experts here, but you can initiate or continue ART in co-infected patients. And your initial ART regimens are the same with or without hepatitis C. INSTIs with TAF-based regimens are preferred because there tends to be no significant interactions. But as a reminder, TAF is contraindicated in individuals with decompensated cirrhosis. But of course, you could potentially use TDF on those individuals. And then as a reminder, Hep C drugs are P450 drugs. So remember to look for drug-drug interactions. And these are some of the most significant drug-drug interactions to consider. And they can impact either the DAA's efficacy, or they can increase, interestingly, Sofdel can increase TDF exposure when it's associated with a boosted HIV regimen. So be aware of those interactions. And, so back to our patient, we'll just take a moment and go back through our patient, whether or not we could begin treatment today, recognizing, concerns that you all have brought up about if the patient disappears, do you want to start treatment or not? If they were to turn out to be hepatitis B positive, again, remember the risk of flare in a co-infected individual is very low, 0.5% risk of total Hep C patients. And the patient's platelet count is 170,000. Remember, platelets less than 150,000 are consistent with a patient having cirrhosis. Cirrhosis doesn't mean you can't treat the patient. It just means that patient needs 12 weeks of treatment instead of 8 weeks of treatment. And so, again, depending on your comfort level, but this is an antibody positive patient. They've not been treated before. Their platelets are over 150,000. Their GFR is normal. We said their chemistry panel is otherwise normal. They're HIV negative. They're not pregnant. We've sent off the RNA. We've sent off the hepatitis screen. So based on this individual could be treated if you are comfortable with that, if you feel comfortable that you have a way to follow up with them, because clearly they are a high-risk individual with their history. Yeah, and then next step, in July of 2025, the California Department of Public Health received $1 million from EDAP funds for rapid HCV RNA testing technology and supplies for local health departments and community organizations, with the goal of further expanding test to treat. Obviously, if you have this point of care rapid RNA test, then you'll be able to confirm for certain if that individual is in fact currently infected with hepatitis C. So there's a lot of excitement around this test. It can be a little bit of a challenging test to use. We put out applications, I think back in April, received applications in early summer and have put out awards for those. I think it's a 23 or 24 total machines that CDPH is awarding. UC San Diego is a recipient of one of those machines. And those award letters have gone out. So this, will give you some added confidence that the individual you're potentially treating is in fact infected with hepatitis C and they haven't cleared if they come back positive. And we're going to be holding a community of practice for the sites that receive the machine. Right now, we're finalizing the data collection that will be a part of the, that recipients will be responsible for. And then machines will start to go out. There are some challenges with reporting to public health through this machine. California is right now, we're looking at something called middleware that can be connected to this machine that will allow for reporting of results, because that'll probably take a few months to actually get on board. In the meantime, there'll be a secure file transfer of results for folks who are tested by the recipients to the state of California. So we can track the results and the benefits of having these machines out in the community. And I do want to add that additional funding has been approved for emergency department screening. Previous funding that went through April of 2026 was 15 million. That has been increased to 30 million for the next 2.5 years. And so we're working quickly to get those contracts and RFAs prepared. And there's 2 rounds of funding that were approved. So this next round for 2.5 years for 30 million, and then in 2029, another 30 million. So it is being fully appreciated, the benefits of screening in emergency departments. And so to conclude, Test and Treat is, as you have seen, supported by national guidelines. It ensures treatment of, often some of the more challenging patients to receive treatment, and it will help to contribute substantially to ending the hepatitis C epidemic, aligning with, you saw the long list of strategic plans that would like to see hepatitis C eliminated. And with that, I'll conclude. I'm happy to answer any other questions.
Great. Well, thank you, Kathy. We can have people unmute if they have questions or type in the chat pod. I'll ask first one. I forgot if you mentioned how quick the turnaround time is for the point of care test.
Yes, yeah, it's roughly 30 minutes. The test does have some challenges in that it's either a 2-test or a 4-test machine that can be run simultaneously. So it's not a high volume test, but if you screen folks with antibody testing, and to me, one of the easiest places to use the machine potentially would be in emergency departments and or labs associated with emergency departments and hospitals. If somebody's antibody positive, then you can know their result within 30 minutes following.
Okay. Jill, do you want to comment on what you put in the chat?
I was just because I learned about this money that Kathy just was talking about, and it's in AB 164. And there's I just popped in like section 95 where it talks about all the different funds that are available, and 4 is the 30 million that Kathy is referring to. Sorry if it's a little confusing there. There's a lot of stuff in AB 164, and it's interesting that it relates to refunds or rebates from ADAP. So the whole thing is fascinating to me, and this is when I wish I understood how the California legislature worked and all of this stuff. But I just wanted to put it in there if other people were interested in reading more about it. So that was it. I was just putting that in. But Kathy, I would be surprised if, unless someone unrelated to our program applied from UCSD, I hope maybe someone did. I didn't think we ended up putting in a Cepheid application. So maybe it's from somewhere else in UCSD.
Oh,
Maybe like one of
okay.
our, I'd be curious. I mean, yeah, we ended up, oh, it was so hard. no one seemed to feel like they could own it, and everything, it seemed too good to be true, and then it turned out it was too good to be true because I think part of the problem is you do have to have enough staff to be able to run it, and that was our issue in the microbiology lab. They're like, we don't have enough actual person power to do it, and then we wanted it in the ED, and they thought it would not like actually be used well and efficiently, and anyway, so I'm curious, maybe one of our like our new campus applied for it or something, but
Hmm. Interesting.
we
Yeah.
can talk offline because I don't think we ended up I was really trying to get it to lots of different places, but
Yeah. Yeah. Interesting. Um,
yeah, you'll have
I,
to let me know.
yeah. And that information is public. So,
Oh, about who was awarded?
yes. Yeah. I mean, I don't know if the name of the individual themselves is public, but the name of the institution that received them is.
Yeah, because we had also talked about this going, this would be a great spot on mobile units for other people of mobile units. And for us, we couldn't get approval from our point of care team. They said we're not even set up to do point of care yet in brick and mortar, so it's not happening on a mobile unit. So
That's
there's a lot of emails I sent trying to, I was like, they're just giving these machines away. I hope others took
disappointing. I was
advantage of it.
excited to have you all, teach all of us more about your experience. Yeah.
Yeah.
Darn.
Well, what I was going to say, Kathy, and I can be
Mm.
quiet if others have things to say, just we're starting officially on Tuesday, which is September 1st. We are officially starting test and treat in the emergency room after many months of getting ourselves prepped and ready to go with algorithms and emergency room department buy-in and whose name is actually going to be on the prescription. That's yours truly, not an emergency room doctor. And like what was acceptable, what was not. And so, yeah, we're going to be starting that on Tuesday with strong involvement of we have three patient navigators that have different roles. So they're all going to be involved in this program. Um,
Excellent.
yeah,
Yeah.
so we'll be excited to let everyone know eventually how it goes. But this was
Yeah.
definitely inspired by the work that you have been promoting. It just took us some time to get there.
Well, yeah, thank you. And we'll have you, once you've got a few months under your belt, we'll have you present at the community of practice because I think the EDs would be very interested to learn how you set it up.
Yeah,
So that's great.
yeah.
Yeah. I got a comment from Adam Bortner. If any place should have a point of care test, it seems like a mobile unit would be the most logical place to start.
Yes. And I don't know if you've heard of the D liver program. I emphasize the D because it's a capital D liver program in with UCSF. They've been doing street medicine with the machine for I think it's about the last year, and have had a lot of success with it. Totally agree. That's a great uh, place for it. Definitely.
And we have a hand up from Nettie Aldis. Nettie?
Hi, I thought it'd be easier than putting in a check. Thank you so much. I'm from St. Cedar Health. This was a great talk. We're working on these similar issues. I wanted to just comment, kind of harkening back to our HIV rapid start, and we kind of all got stuck with like, does it have to be the same day? Does it have to be within 5 days? There was like so much excitement about what does it mean and what are the criteria? And really, the big picture is just that do it as soon as you can. And that's kind of how we settled in, and that message now becomes standard for everyone, including primary care docs. So I think what's exciting about this is obviously, well, twofold. The ER stuff is very exciting, but secondarily, just what will happen is that now the message will get out to everyone, including primary care and specialty and everyone, that this is not so hard to do. So what I'm going to take from this is, if I share this with primary care docs, not to say you have to treat everyone the same day, because not everybody is so high risk and so dire, but that don't make it hard. It's not scary. It's easy to do. So I think that's going to be an exciting sort of second message that comes out of this, for which will affect more than the most vulnerable patients you're seeing in the ER.
Yeah, definitely agree. And the key is really sort of assessing the patient situation and the likelihood that they're gonna, they will come back for treatment versus won't, etc. You all know that. Um, but yes, California is in the process of really launching, um, as you can probably see, test and treat around hepatitis C. In May, we did a virtual training with about 200 providers, and we're going to continue to have ongoing trainings to really try to help folks realize how simple treatment is. I think that's the biggest piece, is that it has felt really scary first. It was it was too expensive and no one could treat except the hepatologist. And I've kind of shared with the hepatologist that I think now Hep C is really experiencing what HIV experienced, which was initially, we as HIV providers told patients or told other providers don't touch our medications. And then we started realizing, wait a minute, if we don't have frontline providers helping initiate patients, we're never going to get HIV under control. Well, now, very similar thing for Hep C. And it turns out it's not that complex as it originally appeared to be. So, yeah, um, we're on the, we think alike, I guess is what I'm saying.
Thanks, Nettie. So it looks like there were some other comments, kind of a little bit offline. Will UCSD test and treat ED program treat patients with compensated cirrhosis? Jill answered yes. And I think that's kind of where we're at. So any other comments, thoughts? Can unmute.
I had a question. I was curious what your advice or guidance would be for institutions or emergency departments where they don't have as rapid of results for HIV testing, or how you would tell them to approach this.
Yeah, that's where I think the navigators and a strong connection with someone like Jill, not that Jill can do that for all emergency departments, but having a strong connection with the EDs, having navigators and a strong connection with someone who's willing to help with the treatment and follow up. Um, and I would add to that, connection to the street medicine teams is going to be super important here as well, because um, as you know, there's a subset of these patients who are not going to follow ups and they're not going to answer your phone. So finding out where exactly they're located so that the local street medicine team can help support them and treat them. So it's really creating that network of support, so that if they test in the ED or they test in an institution but don't have rapid turnaround of results, you've got navigators, you've got providers, and you've got street medicine to all support them on the outside.
That makes sense. Thank you.
And I think a lot of the networks that were created for HIV can really be used for this. Interestingly, often patients who are HIV and Hep C co-infected tend to be more likely to be treated and cured for Hep C, because they're already in care or they're linked to these systems that really help to keep them in care.
Great. Any other final comments before we end? All right. Well, thank you, Kathy, for a wonderful talk. We really appreciate it, and hopefully we will be able to reciprocate by having Jill come and talk for you guys once we get more experience. So I'm volunteering Jill right now. So,
we'll be very curious, and I know the EDs will be curious to hear about your experience. So thank you for pre sort of offering.
Yeah. Yeah. Well, thank you once again. Everyone have a great weekend. Thanks again, and we'll see you next time. Thanks.
Sounds good. Thanks, Daniel.
Bye-bye.
Good to see you.
Thank you.
Yeah.
Good to see you.
Yeah. Bye, Jill. Bye, everyone.